Next paper is by Dr. NIROJ Kumar SAHOO. Is present. Okay. He will be presenting on Enface optical coherence tomography patterns of closure of idiopathic macular hole.
Good morning, everyone. So I'll be presenting our developed on-fast-based classification of idiopathic macular holes. So the basis behind why we discussed or described this was, if you look at the previously described closure patterns, it's either U, V, or W, or type 1, type 2, or the recently classified based on the bands, continuity of the retinal bands. But all these classifications only talk about a single OCT scan. But considering a macular hole is a three-dimensional structure, why should we see only a single scan? So this is why we went ahead with the study and to try to determine how these macular holes are closing on fast OCT. So this was a retrospective study, and we took all the macular holes for the past 1 year, and we used multiple OCT machines to analyze this. The OCT parameters that were analyzed were the OCT pattern of hole closure and the preoperative hole orientation, either it was round or oval. And we measured all the indices also, like MLD, basal hole diameter, and hole height. We also measured the acircularity to see how the hole orientation is. So this is an example how we classified oval and round holes. You can see the first two are oval holes. One is horizontal and one is slightly oblique, and the third one is a round hole. And the closure pattern, as you can see here, we classified the first one as a linear closure. We can see a small line, and both the below two are linear. One is horizontal, one is oblique, and the third one is an indistinct circular type of pattern. So when we analyze the results, this is the baseline parameters. The mean age was around 63 years with visual acuity of around 1 logmar. There were total of 64 eyes, for which 43 were round and 21 were oval, 14 were horizontal, 4 were oblique, and 3 eyes were vertical. Surgical intervention, 25 eyes underwent ILM peeling with ILM flap or a graft, and 39 eyes underwent ILM peeling alone. Based on the on-fast type of closure, 38 had an indistinct centripetal or round closure, and 26 had a linear closure. 17 were horizontal, 7 were oblique, and 2 were vertical. But when we analyzed it based on a logistic regression, we found that the baseline hole orientation was the only factor responsible for the type of hole closure on-fast post-operatively. So it means that if a hole is oval, it closed in a linear manner. If it's a round hole, it closed in a round or centripetal manner. So this is how it we suspect, we hypothesize it to be working. So it's a oval hole, the first one. The second was a round hole. The forces, the opposing force is on the axis where the distance is less. So it closes in a linear fashion, while the round closure, round closure is a centripetal type of closure. However, we did not find any difference between in terms of final visual acuity between these two groups. But when we classified them into holes that are more than 650 microns, we found that the linear group had significantly better visual outcome than the round or centripetal group. We can see in the large macular hole group that the round closure group and the linear closure group had a significantly higher so the p-value, the box is slightly misplaced. Significantly higher horizontal basal hole diameter, but lesser vertical minimal linear dimension. So summarizing, we described different types of hole closure patterns and how it can tell us about the final visual acuity. The pre-op hole orientation determines the type of closure. Holes more than 650 microns, linear closure had a better functional outcome. But future studies will be required to see if there is any relationship between the ILM peeling, whether the flap or graft is affecting it, or the area of peeling is affecting it or not. Thank you.
Did the amount of ILM peel, the area of ILM peel, affect the closure and the kind of closure?
No, the analysis shows that it did not affect it in any way. We measured it post-operatively. That is one limitation. We used the on-fast OCT again to measure the peeled ILM area, but that was very inaccurate. But if a better modality would be measuring intra-op photographs, but that can be done in future studies. Thank you.